Welcome, my friends, to the Bob and Brad podcast, produced by Bob and Brad, the two most famous physical therapists on the internet, in our opinion. Today, I am joined again by my co-host, Mike Keenitz, they have their own channel. It's the Bob and Brad crew, and they review products that are related to health, fitness, and
overall well-being.
And we are joined today, I'm Bob, by the way. I'm one half of the Bob and Brad team. And we are joined by our guest today, who is an associate professor of medicine at Duke University. He is board certified in obesity medicine and internal medicine, and founded the Duke Keto Medicine Clinic in 2006 after 8 years of clinical research regarding low carbohydrate ketogenic diets. He's the past president and master fellow of the Obesity Medicine Association and fellow of the Obesity Society. He is an editor of the textbook Obesity Evaluation and Treatment Essentials and author of the New York Times bestseller, The New Atkins for a New You. Cholesterol Clarity and Keto Clarity. These are all different books. And also new bestseller, End Your Carb Confusion. He's a co-founder of Adapt Your Life, an education. You will mention the website here, www.adaptyourlifeacademy.com. We'll mention it at the end again, and a product company based on low carbohydrate concepts. Dr. Eric Westman, thank you so much for joining us today.
My pleasure. Thank you.
I do want to mention one other thing from the intro. I went and looked on the Duke Health website, and you had 373 ratings from patients and 4.75 stars, but they were glowing reviews of you and how kind you are and how committed you seem to your patients. And you and Roy Williams, is that someone you work with? Is that a nutritionist? But
medical assistant.
Medical assistant. I thought that spoke higher than any of your other accolades.
Thanks for looking. I haven't ever read them.
Well, if you want to ever feel good about yourself, you should take the time, because it's really.
I definitely need that.
So we wanted to talk today about the keto diet and also about carbs. That's the general overall view we want to take. Towards the end, and maybe in another video, we're actually going to talk more specifically about weight loss, which of course intertwines with all of this anyway. So Mike and I are going to take turns asking questions. Mike has had a lot of experience with keto.
Yeah.
And I've read your book, End Your Carb Confusion, a simple guide to customize your carb intake for optimal health. Very well written, and you attributed some of that to your help, that you had an assistant author.
Yes, yeah. The secret to having a great well-written book, if you're not a writer yourself, is to do it with a writer who can help operationalize. Yeah, Amy Berger, my co-author, and I both put the book together. Thank you.
It's awesome, really, really well written. And I thought it took away the people who might be intimidated by the keto diet, that it's so simple to do.
Or some of the misinformation that's kind of out there now.
Right, lots of misinformation. I think you alluded to that when we were talking earlier on the internet. I don't know if you want to speak to that or not, but there's apparently a lot of wrong advice. Is that the way?
Yeah, well, it's confusing today because the internet is a great thing and a terrible thing. Internet keto is now this kind of confusing array of products that I don't ever recommend. So I teach the classic kind of approach that helps people lose weight and reverses diabetes. And the way I like to explain it is that a keto diet really is just one that's very low in carbohydrates. Carbohydrates are sugars and starches, and you burn what you eat for fuel. So because you're not eating and burning carbohydrates, the sugars and starches, the alternative fuel, or I think it could be viewed as the primary fuel when you're not eating carbohydrates, becomes fat. So actually it's a fat burning diet, a keto diet. But the thing is, the pop culture, the world isn't ready yet to be told that it's a fat burning diet, because we were all taught that you shouldn't eat fat, and that fat was bad. So enter in the term keto, which is sort of really just saying fat burning, because you're not eating sugars, you're not burning sugars, you're burning fat. But, you really can't say that it's high fat because, the world isn't ready for that. So keto is right in that middle there. And ketones really are just molecules like glucose that get used around the body for energy. But it's really a fat burning diet, a keto diet. But then that gets confusing because someone came to my class. I'm teaching this in a real world setting in a clinic at Duke University. It's a university-based private practice, and people come from all walks of life, all ranges of education. And I once said I trial ballooned in my class what's really just a fat burning diet, and this person gets up and says, "Well, I'm leaving because I want to lose fat."
Oh,
and I mean, so no, it'll help you lose weight, but everyone thinks of it as a weight loss diet or a weight loss program. When really keto means that you're burning fat, and but that anyway. So you have to kind of explain it in the way that people are ready to understand it, or the depth. Do you really want to know what ketones do? And I mean, or do you want to know what food to eat and not to eat? I mean, so there are a lot of different ways to teach it. And the keto diet now on the internet, you might think that you have to have this, ketone drink to do keto, when what we teach is what we've studied at Duke now for 20 years. It's based in real foods. In fact, the program that we use had its origins in something called the Banting diet back in the 1860s in London, England. It was the first diet book ever written. And so then if you look back, the doctors in the mid 1900s, Dr. Atkins, Dr. Eads, Dr. Bernstein, well, Dr. Bernstein's still in practice, actually, Dr. Rosedale, they all used kind of low carb. Keto was the first phase of all of their approaches. And so keto today borrows from all of that history. But if you're trying to lose weight or you're trying to reverse diabetes, I strongly urge you to learn about the keto that we teach, the real food-based ones, because today people get off track by, the shiny keto product, and then they're guzzling, thousands of calories, trying to lose calories off their body, and that doesn't work so well. But
so Mike and I had a riveting discussion prior to you coming aboard here. Now, I'm again not an expert by any means. I just read your book, and from my understanding, it's about reduction of carbs and not necessarily addition of fat. Now, Mike's saying
I was explaining that if you're just going to eat chicken breast and broccoli, you're probably not going to feel very good, even though your carbs are still low. And he wasn't believing me.
So this is a great question. And so historically, the use of this kind of a program for weight loss really was lean meat and a vitamin. It was called the protein sparing modified fast. And then the researchers stopped studying. They got distracted by drugs and surgery for weight loss, the group at Harvard. But if you have fat on your body, you're going to be filling in the fat so that it actually works for weight loss if you're just eating protein, if you have extra fat on your body. And you're getting the minimal. There are some essential fatty acids, meaning you have to eat them. So, and you're getting the fatty acids with the food that you eat. If it's a meat product like protein, like chicken, poultry, fish, shellfish, eggs, that sort of thing. Yeah. So one of the confusing elements today is that the ketogenic diet for epilepsy, which really focuses on macro counting and the ratios per meal, that was developed because some children will have a seizure if they don't have the right macro level. Some children will have a seizure if they eat carbohydrates because their brain can't use sugar, can't use glucose for energy. It has to use ketones. And almost miraculously, some of these children have resolution of their seizures overnight when they stop eating carbohydrates. So the ketogenic diet was not developed from the Banting diet in England. It was developed by a group in the US in the early 1900s, ketogenic diet, Mayo Clinic, Dr. Wilder, and then Hopkins. And they are focused on the macros. And this, I see this in the internet keto that some people think they have to do by getting an app and making sure every meal is a certain ratio. And some people even check their own ketone levels with the blood and the urine.
I like to experiment. I'm curious.
Mike checks his kilos.
Well, that's fine. You can do it if you want to, but you don't have to.
Yeah.
So remember, before there were any keto monitors, Mr. Banting actually in England had a diet book that worked really well without measuring ketones or macros or all this. So yes, the tech stuff is kind of cool and you can biohack and all that, but you're going way beyond the published science if you're going to be fine tuning in that way. But I think the macro counting and the worry about getting ketones and the fat protein ratios comes from the ketogenic diet for epilepsy. And that's not what I teach. I'm not that strict about it. You know, if you eat a thin mint Girl Scout cookie, you're not going to have a seizure. You just won't lose weight that day. I mean, if you eat 4 of them, right? So you want to keep the carbs really low, because if you eat carbs, you burn carbs. If you don't eat carbs, you're going to burn fat. And most people who come to me want to burn fat off their body. And actually, so it's interesting, because if you have fat on your body, I'd rather have the fat come from your body than from what you eat. From the weight loss, diabetes reversal perspective.
So you're absolutely fine with lean meat then, if you're trying to burn fat off.
Yeah, because I mean, lean meat, what does that mean? I mean, it's kind of like, you know, fingernails on the chalkboard, if you remember that metaphor, because you don't have to have lean meat. So the fat that you eat will, though, interfere with the fat that you burn off the body. You know, the type of keto diet that we teach, the low carbohydrate keto diet, we don't teach counting calories at all, because the hunger goes down for just about everyone automatically. And they end up eating kind of a low calorie diet as defined by the nutritional people, about 1,200, 1,300 calories a day. But you can actually augment the weight loss if you consciously lower the calories on a keto diet. I mean, it's all about how do we comfortably get people to eat less in a world where there's food everywhere, and you know, all the programs that lead to weight loss have to have you eat less than you were before, and this one is just kind of, you know, automatic and almost miraculous, because after a day or two you're just not hungry. Yeah, and I have the worriers who come in. Well, what about? I said, look, just try it for a day. Just try, you know. Well, but what about, you know, no, the hunger will be gone in the equation. Your perspective changes. Now you're in charge, because you're not hungry, and that donut doesn't call your name. You know, you're not driving over to the donut place anymore, because you're just not hungry. But there are all sorts of, part of the confusion today is the measurements of these things and the worry about the calculation. And yes, I'm okay with lean meat, because actually over time, so I want to teach something that you're going to be comfortable with over time. People will gravitate toward, well, that's pretty tasty. That, you know, that ribeye. So there's a kind of a strategy at first. If it makes sense to you to have lean meat, because, you know, you've been taught that, fine. You know, if I'm teaching you to ride a bicycle and you've never tried low handlebars, that's okay. I'll teach you to ride the bike with regular handlebars, and then one day you're going to ride the bike without hands, you know. So, but there's kind of an art to teaching it in a way that's consistent with prior beliefs, so that it's easier for someone to kind of wrap their head around it.
I also like that in the book, you basically state that you're going to focus on the diet first. You're not going to worry about sleep. You're not going to worry about exercise. Those things can come later. But right now, put your entire focus on the diet, which is going to have the most benefit, according to the book.
Yeah, you know, most doctors are not trained to help people lose weight. I mean, we just don't get training. And I bet you didn't get nutrition, weight loss training in physical therapy school either, right? I mean, we've kind of outsourced it to a group that thinks low-fat diets are the only thing you can do. That's the Academy of Diet of Nutrition and Dietetics. And although they did invite us to their annual meeting pre-COVID, us meaning Finney, Volek, and Westman were the authors on the new Atkins book, and we are researchers and scientists. So there's a glimmer of hope that the organization will adopt or allow for this. Mid-career, I realized I didn't have the tools to help people lose weight. I found this group of doctors who had been helping people lose weight for 50 years. It was called the American Society of Bariatric Physicians. And at that stage, everyone thought bariatric meant surgery. So I would go to a meeting. I'm president of the American Society of Bariatric Physicians, and they, oh, what kind of surgery do you do? I said, no. And so the next year I'd go, I'm the president of the American Society of Bariatric Physicians. The medical doctors, not the surgeons, they'd think for a minute and go, oh, what kind of surgery do you do? Bariatric is now in everyone's mind as an operation,
right?
Or surgery. Right. So a group of us, we didn't create the organization, but we're the second generation. We said, okay, we got to change the name. So the name is the Obesity Medicine Association. Awesome. And there's actually now a formal board certification process called the American Board of Obesity Medicine, ABOM, and you can get certified in advanced training as a medical weight loss doctor. So I went out to learn on my own and then learn about nutrition by myself, because we just weren't given the tools to help people. And all I do is change the food. I don't ask people to exercise. And I know that people say, oh, I didn't even try to lose weight because I know you have to exercise to lose weight, and I have a knee problem and I can't. No. If I strapped you in a wheelchair or a hospital bed and didn't feed you, you would lose weight, right? And, some people think, well, no, I don't think I would. No, come on. If you don't eat anything, you're going to lose weight, And then I'll use the even crazier analogy of, have you ever watched these reality TV shows where they go for 3 weeks and they're out in the wild and you can see the pre-post pictures and the weights, and they lose a pound a day of weight because they're not eating anything at all.
Intake.
So diet is the most important thing. And then there are the kind of doctors who say, well, it's 80% diet, 20% exercise. No. It's 100% diet. Remember, if I strapped you in the chair and didn't let you eat, you would lose weight. That's 100% without any exercise. So we target diet first. And that's because in my clinic population, most people don't have the energy, they don't have the joint function to be able to exercise at all. And so doctors often, not only do we not know what to say that works, often we say what doesn't work to people. Right. And reinforces. So I used to say, just exercise more, or just eat less, and that doesn't work. And so now I explain to someone, all I do is help people lose weight. If what I didn't work, I wouldn't have a job, because people wouldn't come back. And I'm within an insurance system, so actually I would get paid if it didn't work, but don't tell anyone that. I'm in the insurance system so that people can get the services through insurance rather than have to pay out of pocket for things. And there are a growing number of insurance-based doctors doing this. But so I'll say, look, I don't want to waste time on things that don't work. I'm not even going to talk about exercise. And actually that relieves, where you can just see the look in people's eyes saying, well, I was so worried because I thought you had to exercise. No, you don't. So we start with diet alone. And it's actually pretty amazing that you can do so much with just changing the food, because that's another whole, who knew that eating really good food was really important? I wasn't taught that as growing up with Frosted Flakes and Captain.
Exactly.
Anyway.
Well, Mike, do you want to ask a question about?
I'll probably just ask this right now.
Oh, sure.
I guess the next question would be, how did you find out about the keto diet originally?
Yeah, so like most doctors, I didn't get any training in how to help people lose weight or even proper nutrition. Maybe I had a few lectures about total parenteral nutrition, which is where you take over the food in the hospital for people, take over the nutrition even in the vein. But there were two of my my patients in an ambulatory care setting at the VA hospital in Durham. I was working at the Veterans Affairs Hospital, and 2 of my patients did this diet and lost weight, which was this was an outlier, definitely. Most people did not lose weight. Even if I sent them to the dietitian down the hall, they didn't have success. So I was curious and said, well, what did you do? And, one of them looked at me in the eye and said, well, all I did is eat steak and eggs. And I was like, well, whoa, that can't be good for you. And then he said, well, I read this book. It's the Atkins diet book. It was written before you were born. Now that was getting a little,
personal,
close, but it wasn't before I was born. But so it was really through my patients that I learned about this, and was curious because nothing else had worked up until then. And then, like most doctors today, I read a little bit about it and said, your cholesterol was probably going to go up. Don't do that. And one of the patients said, why are you afraid of this or concerned about it? I said, your cholesterol will go up. And he looked at me and said, well, why don't you check it? And I was like, okay, checked it. The lab was down the hall and it was better. So,
wow.
So this is like, if something can't happen and you see it once and then twice and then a third time, I wasn't so overtrained to ignore what was happening in front of my face. So I started to question maybe this did work and how wonderful that would be. These people didn't even need a doctor to lose the weight. They did it all on their own.
Sure.
So out of a kind of curiosity, I wrote Dr. Atkins a letter. He was in practice in New York City. This is going back to 1998. And he called back and asked a few questions and said, well, why don't you come up to the office and see what I do? And so we had a day in New York City and I pitched him a study. I had a 1-page, hey, why don't you do this study? You're gonna have to pay for it. And he pulled out his checkbook and wrote the check. And I was like, well, this is a pretty easy study to get. So we did it 6 months. It looked great. We went 50 people over 6 months. We published that paper and then went back. They had created a foundation. So we did a randomized trial looking at low carb keto versus low fat. And this is now one of about 30 studies that had that same low fat versus low carb parallel design randomized controlled trial. And so Dr. Yancey and I were the Duke group, and then Dr. Volek at UConn, University of Connecticut, now at Ohio State, we're both starting to do clinical studies on the Atkins diet. And really today's keto diet is like the Atkins induction diet, meaning it's that first phase and it's using total carbs, not net carbs, which is another cause of internet keto confusion today. It's not that it can't work, it's just not quite as powerful. But sadly, Dr. Atkins died in 2003, before I could really say, hey, teach me. I mean, so I didn't work with him day to day. There were some other doctors that did, and they took over a lot of Dr. Atkins patients in New York City. But I applied for research, and now the research has been done all over the world, finding similar results, that cutting carbs down lowers the glucose, lowers the insulin, you lose weight, you can reverse diabetes. And probably the 20 years of this research, the pioneering study in diabetes done by Virta Health out of Silicon Valley. It's a company that uses a keto approach for diabetes. Their paper is just fantastic, showing reversal even with people on insulin. And I see this in my office all the time, but to be able to say, here's the research publication is a huge bonus. And I think that's going to turn the tide in terms of the mainstream medical people paying attention to it.
Sure. Because that was one of our questions is, why do you think so many doctors are against keto, are really not accepting of it? I'm going to give you an example here. A family member, she's been getting her fasting glucose tested, and every year it's been going up a little bit. And her doctor said she's going to eventually develop type 2 diabetes, even though she's not pre-diabetic yet, but just the fact, seeing the pattern. And he said, there's nothing you can do about it. I mean, you're headed that direction.
Well,
so,
Yeah, most doctors don't know. They only know what they see. Or there's the old saying, we practice like we were trained in residency, which, for me was 30 years ago.
Right.
It would be like saying, I still use a phone with a cord on it.
Sure. Sure.
So I'm starting to use that metaphor because actually, Silicon Valley is where Virtual Health, the biohacking sort of thing, is taken off. And, if they, went to my mother and asked, is it okay for us to use chips and all these things? My
Right.
mother would say, well, no, you need a phone with a cord.
Yeah. Yeah.
So
Exactly.
well, but all kidding aside, we were taught that it was bad. We weren't taught that smartphones were bad, right? I mean,
Right.
we were taught that eating fat was bad, and a whole generation
For years and years.
Yeah, a generation. I mean, really,
Yeah.
and
Yeah.
we taught,
Exactly.
and it really is. I'm so frustrated that someone who's in their 20s, 20 years old, my children's age, will come in worried about a cholesterol level. It's like, oh no, not. I mean, even the new generation of kids, they were worried about cholesterol, and I don't want people to be worried about cholesterol. I want them to be worried about the blood sugar.
Right.
And in fact, one of the videos I'm going to do soon is, if your doctor has recommended medicine for diabetes, watch this video. And what I'm going to do is talk about how lifestyle change fixes, reverses, and even prevents diabetes. So I'm afraid the doctor who has that response, has this crystal ball of prediction only of people who are eating carbs and eating, garbage and junk food.
Well, garbage, I like that. That's awesome. Garbage.
Yeah.
Mike, why don't you ask another question?
I guess you already kind of talked about checking people's insulin levels, but what are other lab values like you would look at for your patients? Just like, what are some good markers? Like, say I go to a normal doctor, they're still concerned about all these things. What are some things I could ask them? Like, well, can you look at this lab value? What would be a superior lab value, I guess?
Yeah, well, so I'm an internal medicine specialist and trained as an obesity medicine specialist. So I have a general training. I don't do that kind of practice anymore. I'm a specialist in lifestyle and even keto medicine. But I think the generally accepted things to measure, there are these things called vital signs when you go in. Blood pressure is still one of the most important, it's not a blood test, but it's a test you want to know. And, that's a whole nother miraculous story. Who was the first one to think about measuring someone's blood pressure? It's a fascinating story. But so it's really the glucose, the sugar axis, not the cholesterol axis in the blood. What I mean is the parameters that have to do with elevated blood sugar, elevated insulin, hemoglobin A1C. These are the things that you want to have checked, not the old total cholesterol LDL thing. It's called metabolic syndrome when you look at triglyceride and HDL and the waist circumference. And so that's the other vital sign is the weight. And you adjust the weight and the height to get a BMI. And, if you're not at a gym where you have muscle-bound people, the BMI is actually a pretty good predictor. And it's now in a recent paper in JAMA Cardiology that I want to talk about a whole lot with other doctors, shows that these classic risk factors include smoking in there. And I came through the nicotine smoking cessation world for 10 years, where we tried to get smoking status as a vital sign, because it is so important to reduce the heart disease, which is really what all of these things are trying to prevent. So smoking, blood pressure, BMI is a great predictor of future heart attack, of future cardiovascular disease. And then it's the having diabetes is the worst thing you can have in terms of future heart disease. So again, we're trying to prevent. And of course, if you have these things, you have to know that you can reverse diabetes in most cases if it's type 2 diabetes. So kind of, the one number, if you really press me, It's an insulin level that you really should have checked. And the problem is doctors don't do it. They'll say, oh, we don't measure insulin levels. So if you measure a blood sugar level, it might be normal, but at the expense of a really high insulin level to keep it normal.
Sure.
So there was this old-timey test called the glucose tolerance test, where you gave a sugar load and then you watched the blood sugar and the insulin over time. Some of them didn't have insulin in, just the glucose. But if your insulin level is high and a doctor wants to put you on insulin, you don't need more insulin. It's already too high. You want to take action to reverse the insulin level, not add more insulin. So I'm afraid my internal medicine endocrinology field has gone down the pathway of adding medicines and even adding insulin on the medicines to treat diabetes when the insulin's already high, and it doesn't fix diabetes or reverse it, it just manages it. I mean, have you heard that on the ads on TV now? Again, it's like the fingers on the chalkboard. Manage your diabetes with this medicine. Oh, no, you can actually reverse it.
Sure.
Yeah.
And I just want to add that in your book, you do actually talk about, the tests and kind of the whole insulin dependent and or the whole syndrome. So it's explained well in there. So I have another self-serving question here. So another family member really fits your profile exactly for someone who's carb intolerant. Has polycystic ovarian syndrome, is obese.
PCOS.
Has
PCOS.
PCOS, has migraines, hypertension. So do you have any, I know you've done a lot of studies. Do you have any sense of the success with people like her, diabetes, or, what is the success rate?
Yeah, 100%. All those things will go away.
Wow.
I mean, 95%. I mean, but you have to do it.
Right.
So you can't mess up or intertwine I couldn't do it, so it didn't work. Well, that's like saying I prescribed you a pill and you didn't take it.
Right.
Don't blame the pill for not working if you didn't take the pill. So actually, all of those are manifestations of carb intolerance and or insulin resistance. And so I don't oversell in my office. I'll say, well, there's a good chance those things will get better, because most people who come to my office they're not attracted to the doctor saying, oh, everything will get better. All that. They want me to be more stoic and
More
just,
measured.
Yeah, more measured in my way of saying it. But yeah, all those things get better.
Oh, that is awesome.
The PCOS is fascinating because polycystic ovarian syndrome, PCOS, is insulin resistance, and it affects the ovaries by making women more like men. It makes more testosterone. And I'm afraid that getting obese really makes women more like men and men more like women. The extra breast size.
Right.
And so that's just obesity in general. Now, because that gets better on a keto diet, you get all of those benefits. And at Duke, we have a great fertility program. I mean, it's state-of-the-art academic program, which means they're using medications. They don't address lifestyle.
Right.
So I'll have people they have PCOS, they don't have periods, they have infertility, they can't get pregnant. They'll go through all of the high expensive programs and procedures, all these pills and drugs.
Very expensive.
And even like in vitro stuff or in vivo fertilization kinds of things. And when it doesn't work, the doctors there will say, oh, well, maybe you should lose some weight. And then they end up in my office, and within a month, they're pregnant.
Oh, wow.
1 month. Now, how could that be? It's metabolic, it's hormonal. It's that change so it's the carbohydrates and the insulin that change the testosterone level. And it's very powerful. But so, if there was one thing that I wish I knew, if I could go back, tell myself, at age 15 or, the old thing, it's, what you eat really matters. You wouldn't put dirty fuel in a car.
Right.
I mean, not that you can. I mean, one of my patients came in, he was all distraught because by mistake he put diesel fuel in a regular engine, and it destroys it. I mean, I didn't know. I've never tried it. I've never, but
I didn't know that either.
Ruined his car.
Huh.
Yeah, don't try this at home. but where did it happen that we kind of lost our minds in terms of maybe what we eat and drink
don't
matters to our function? Doctors gave it up in the mid-1980s. You don't have in medical school, DO schools, they don't teach nutrition. And I would love to see a medical school or PA or physical therapy school come up, and the dean gets up or the professor says, the most important thing, we're going to talk about this, that, and the other thing, but what you eat and drink is fundamental to health.
Yes.
Mm-hmm.
I mean, how radical is that?
Right.
Maybe, do you want to talk about, since I'm keto and I've been keto for like 4 years, newcomers typically ask me about keto flu. Do you just want to like talk about that a little bit?
Sure. Yeah, and I wish it wasn't called keto flu.
It's misleading.
You're
not gonna vomit and get sick.
Keto headache, and most people don't get it. Occasionally you might have flu-like symptoms and be laid up in bed. I think the worst case, someone said, I was in bed for a week, and then I always wonder, really 7 days, or did it seem like a week? But in the studies that we've done, and most people don't get a keto adaptation sort of syndrome. So when you go, that's really what I prefer it to be called, but let's call it keto flu. Most people don't get keto flu. So if you're worried about it, don't be deterred from trying it.
Sure.
It's headache, it's fatigue, it's cravings, although some people say cravings are part of a withdrawal syndrome from stopping carbs. So really what you're going through is more complicated than just transitioning from carb eating and carb burning to fat eating and fat burning, but it gets all glommed together as keto flu. There's things you can do to reduce your chances of getting it and the severity of it. One is adding in salt or in the form of bouillon or electrolyte formula. And of course, if you have high blood pressure or a history of heart failure or a kidney failure, you don't want to add in salt. And I always have those disclaimers on there, but for the general public who's otherwise healthy, you just add a bouillon once or twice a day to hot water, and that will reduce your chances of getting keto flu. Most people sail through the first few days, first week, without any trouble at all. It's really pretty amazing. And you're just changing the fuel source from what you eat, the carbs, to, fat, because that's what's remaining when you don't eat carbs. And then you start burning your body fat so well, your hunger goes down. You don't need to be eating. And then if most people understand that if you have sugar, it just makes you want to have more sugar. There's no stop valve or stop, if you have a whole bag of M&Ms or popcorn or anything, I mean, you eat the whole thing.
Yes.
There's no break, that says, okay, I've had enough popcorn. It's like, it's the bottom of the container. I guess I'm done.
They're definitely trigger foods.
Yeah, hyper palatable foods.
Yeah.
I would say I kind of got it, but I was under the preconceived notion that I could still train very intense. And that just basically replenished my electrolytes. Mine was just electrolyte issue when I had it. I just kind of had to learn the back off intensity of working out early on, and then ramp it back up later on when I felt better, I guess.
Yeah, so give yourself a break. If you're exercising, you're in the gym, don't, give a few weeks or so. There's a movie or a couple movies, one called Serial Killers, Cereal, and Serial Killers 2. These are documentary films about athletes doing keto diets. And they're fascinating. It's packed with information. Serial Killers and Serial Killers 2. And what made me think of that is in Serial Killers 2, one of my teachers, Steve Finney, teaches these two triathletes how to fat burn and then wait until they were totally fat adapted, meaning they were actually measuring how much fat they were burning. And then they would be put in a rowboat and then row from San Francisco to Hawaii in the open sea, which was it's a fascinating movie.
Wow.
Well, but they waited 6 months because they still were adapting and able to burn more fat over a 6-month period. You see, they didn't want to take the chance of only being halfway adapted if they're going to break the world record. So, if you want to, use this in your kids' soccer team, don't do it the week before the season starts.
Mm-hmm.
You're going to train them in the off season so that they're already keto adapted and they'll have amazing stamina. And by the way, so Sami Inkinen, who was in that rowboat with his wife, broke the world's record of rowing from San Francisco to Hawaii by 15 days.
Oh my God.
I don't remember. I think they won it. They did it in 45 days. And the prior record was 60 days.
Wow.
Constantly rowing and sleeping and all. And it's a great dramatization of, yes, you can run on fat when you're doing this kind of activity. A little trivia is that Sami Inkinen, the guy in the movie, is actually one of the founders of Virta Health, the company that's using diabetes. Same guy, and so he's driven because of his personal results. And then the other kind of exerciser that my clinic, my comfort zone is diabetes, obesity, people, giving people permission not to exercise while they start the diet. That if someone comes in like you who's already exercising a lot, I'll refer you to these movies, to Professor Noakes, who wrote Running, who became a anti-carb guy or fat burning. Zach Bitter is the 100-mile race ultra marathon champion, and he's got zachbitter.com. And there's also a product that I don't know much about, but the owner teaches keto, and that's vespapower.com. And I refer people for those clinical sources of teaching, because I hear a lot about this and go to meetings where people are using it, but that's not my clinic. I don't have thousands of people who've done exercise.
Sure.
Yeah, I think Volek kind of wrote the low carb performance book too.
Yeah, so Steve Phinney and Jeff Volek have 2 books that are kind of the advanced course I would recommend: The Art and Science of Low Carbohydrate Diet, Low Carbohydrate Living, and The Art and Science of Low Carbohydrate Performance. Those are excellent little monograph books. They're not huge, and that's the advanced information if you are exercising and want to know more about it, how to keto adapt. And you get great stories about the Inuit, the Eskimo folks who didn't eat carbs. And Steve Phinney, one of my teachers, wrote those books with Jeff Volek. And it's great to it just helps, because we were all taught that this was something you shouldn't do. And yet there's all sorts of information that if you look for it, it really supports it. The paleo, primal, ancestral health movement, it's really saying the same thing in a different way. Now, a source of internet confusion today is the concern about food quality, whether you have to get grass-fed beef.
That was one of our questions.
Yeah. No, you can talk about that now.
Yeah, talk about it.
Yeah, but so I've never recommended those things because in my clinic in Durham, most of my patients won't do that. They don't have the money. We don't have the resources here. We finally have some grocery store chains that carry a lot of this stuff, but most people can't afford it here. And so I teach an approach that's not overly concerned about food quality. I can't remember the last time I ate at McDonald's personally. And remember, this isn't about me, but many of my patients just eat at McDonald's or Burger King or Wendy's. And they taught me that you can actually go and have 2 burgers or bacon cheeseburgers with no buns and no fries and no sugar in the drinks. And they lost 100 pounds.
Wow.
So, so what I teach is kind of the fundamentals of, here's what you need to know about carbs. You can do it in so many different ways. I really don't want to give here's a cookbook with a meal plan and all that, because that's limiting. It would limit you to think oh, you have to have this kind of recipe. No, it's really, once you understand the basics, when I teach you to ride a bike, you can ride anywhere you want, and I remember the look in my kids' eyes when they were like, see ya, Dad, And so that's my approach, is to like bring people in, teach them, and then, you can learn this and do it. Although a lot of people do need or do want the support at first.
Sure.
Much like training wheels on the bike, or doing it on the asphalt at first, or grass even. Eventually you can be mountain biking or making your own food. If you want to do buy the half of cow with a friend and put it in the freezer, from the farm nearby, great. I mean, so that's now introduced the element of, let's change food production in the US with my dollar.
Right.
So if you're thinking, well, I want to use my money to try to change the agribusiness, then you want to go to your farmer's market locally.
Sure.
You want to spend food on the money on the highest quality foods, and I do believe that will drive the people in this direction. But you don't have to do those sorts of things.
Yeah, you're taking into account people's reality, and if you don't, they are going to fail, like you mentioned. We kind of touched upon this a little bit, but would you know? I feel like I could read your book and do the keto diet. Now, do you recommend people trying the book and maybe your website, and you got some classes there, or do you recommend they should get medical help? I know you mentioned in the book that if you're on medications, you probably are going to have medical help, because you might be have to be off those medications fairly quick.
Yeah, so over 20 years, I've learned a lot about the safe use of nutrition. And now that nutrition is powerful, it's probably the most important thing you need to know about how to maintain the human body. And most doctors don't get trained in it. But I've learned that it's really just healthy eating what we're teaching. And so it's not internet keto, it's real food,
Sure.
low carb, keeping carbs low, eating good sources of protein and some vegetables, and limiting the fats. You don't want overconsumption of cheese, cream, things like that.
Okay.
But if you're so the medical world, my medical world, internal medicine has sort of gotten wrapped up in its medication treatment. That's all it really knows and all it teaches. And, my understanding of medications is important because I can take people off them safely. So yeah, if you are on medications like diabetes, high blood pressure, or let's just say any medicines, not topical skin things, but
Right.
Make sure if you don't, if you're not health trained, you're not a nurse or a doctor or a physical therapist who knows about diabetes and blood pressure, do this with a doctor who knows about it and will help you get off those medicines. One problem today is to say, do this with your doctor, is most doctors don't know about it. Mm-hmm. So now you need to find a keto-friendly doctor, and there are more and more keto-friendly doctors, but they're not on every corner. So the safe use is, if you're on medicine, don't do this full bore. You might go in that direction and notice how the blood sugars and the blood pressures are changing. And I'm a big fan of home monitoring. I've never prescribed a CGM, which is a continuous glucose monitor. I know a lot of doctors are doing that. Yes. I like the idea.
I got a friend that has it, yeah.
But the home monitoring of blood sugar is necessary, really important if you're on medicines for diabetes, and the home blood pressure monitoring is really important if you're on medication for blood pressure, because then you'll see changes happening between visits. And often, so I learned this the hard way. There's someone who a month later came back and had a low blood pressure.
Oh, sure.
This was years ago, before I need to now, if it's trending down, I need to kind of anticipate the blood pressure is going to keep coming down. You want to, for the safest use, you want to do this with a doctor or practitioner who understands how to use it. But if you have no health problems, this is just changing to another healthy pattern of eating. And I think there are lots of ways to be healthy. I mean, and End Your Carb Confusion, we talk about low glycemic diets and low carb diets that are nowhere near keto diets, but that's if you're not carbohydrate intolerant, if you're not insulin resistant, you're not diabetic, you're exercising a lot. If you have a metabolic flexibility, you're able to eat more carbs and be healthy. From a clinical standpoint, be careful if you're on medications, because the medicines can become too strong.
And you do mention in your book, I think it was a website called, a couple of websites, but was it Ketogenic Docs, where you can maybe find a ketogenic doctor in your area?
Well, even since this book was published, and that was just in December, there's an organization called the Society of Metabolic Health Practitioners, the SMHP. I'm on the board. We created this organization, the Society of Metabolic Health Practitioners, to be inclusive of all professionals. So physical therapists can join. Hint, hint. Dietitians can join. Medical doctors can join. So all you need to understand is that we are focusing on metabolism. And it's not keto. While we have a guideline on carbohydrate restriction, which is the medical literature term, carbohydrate restriction, we will include anyone in this organization, regardless of what food they're pushing or even what medication, if it's related to improving the metabolic health of people. So that I'm really excited about that. We just launched this organization to be, I'm afraid this happens kind of over and over, where new organizations have to come to be because the other ones just don't embrace. They get off into a direction that they can't, you're telling people to eat fat. I mean, we can't do that in the Academy of Nutrition and Dietetics.
Right.
I mean, or you're not allowing, the Obesity Medicine Association, I'm a past president of that, only allows doctors and physical or physician assistants and nurse practitioners. They don't allow to be a voting member, a dietitian or a physical therapist. So now you're getting into what kind of organization so I'm really excited about the Society of Metabolic Health Practitioners.
Yeah, we'll have to make sure we put that in the
I can put that in the description below.
Mike, do you have another question?
Do you just want to briefly talk about your 3 stages in your new book?
Yeah, so End Your Carb Confusion is kind of the amalgamation, the summary of my 20 years in the low carb research arena. So I've studied low fat diets, I've studied low carb diets, I've studied low glycemic diets, I've studied keto diets. And so what End Your Carb Confusion does is allows you to get a good gauge of where you might fit. So we have a table that you go through, the checkbox system, and then it will fit you into one of 3 categories. And the categories are based on the carb level for the day, not per meal. And then the way you determine the carb level is using total carbs, not net. So the science says that it's more precise to use total carbs, not net carbs, because you get this variability of some people absorb fiber, others don't. Some people have the sugar alcohols affecting the metabolism, others don't. So we use total carbs, not net. And then, roughly you get into a category of 20 or below, which is kind of my total carbs. 20 per day will get everyone into ketosis, even the most severe diabetic, people with insulin resistance on medicines.
So that's phase 1.
Prescription strength is that 20 gram or less, phase 1.
Yeah.
And then, but now let's say you've reached your goal with phase 1. What are you going to do? Well, many people can transition to phase 2, or some people actually end up in phase 2 from the get-go because you don't have a major metabolic issue. So we teach people how to make those transitions. And I mean, spoiler alert is you just do it really slow. Slowly compared. You don't want to go back to what you were eating that got you here in the first place. And then you want to focus on really nutritious foods, not go back to all of the junk in the middle of the grocery store,
Gotcha.
And then phase 3, I mean, phase 3 is my brother basically was always the one in the gym playing basketball in high school and in college, and could eat fruit all day long, never gained a pound. And so if you're naturally active and you're an exerciser and even like to eat those kinds of foods, you may be able to eat up to, again, with sort of a arbitrary number, but up to 100, 150 grams of carbs for the day, which, that from my perspective, that's a lot. But if you're otherwise healthy, there are a lot of ways to be healthy. You don't have to be keto. Although what we've learned over the last 20 years is you can be keto if you're paying attention to eating real foods, and it can be healthy. It might even be more advantageous. And, we don't get into this in the book, but at the keto conferences, we do a lot where the lower your insulin level, if you're a worm, in the research setting, if you're a mouse, if you're maybe even a human, or primates, they've looked at, the lower the insulin level, the longer the organism lives.
Interesting.
So you can be eating in a manner that keeps insulin down, you probably live longer. And we're talking like 10%.
Wow.
10% of a human lifespan, you could be 10 years. We're not talking, if you exercise an hour, you gain a minute of life at the end of your life, that's a trivial amount. But so the real keto crazies, and there's a conference called the Metabolic Health Summit that has put together the keto for epilepsy, the paleo, and then the low carb for diabetes, obesity researchers all in one place. Metabolic Health Summit. We kind of brainstorm about how great it is and all that, but I'm still not. Again, I want the level of evidence to say, yeah, you're going to live longer before I say, yeah, you're going to live longer. But we kind of look at it thinking, this has promise.
Sure.
Really, because you want to keep that insulin level down.
Well, it makes sense. I mean, Mike, do you have another question, or you want me to take one?
I guess the question would be, I know like Dr. Bernstein, he's a type 1 diabetic and he eats keto. Do you work with any type 1 diabetics? I know type 2 diabetics always go to this and can reverse their diabetes. Type 1, it's a little different. Do you just want to talk about that?
Sure. Years ago, before I started doing research on the low carb keto diet, I visited doctors who were doing this approach. I visited Dr. Atkins in New York City. I visited Dr. Bernstein, Dr. Richard K. Bernstein, who lives outside of New York City in Mamaroneck. And to this day, he's still working out of his office in his home. I visited him 18 years ago and then just a few years ago, and a brilliant pioneer. We stand on his shoulders. A great story of fixing his own type 1, I wouldn't say fixing, but managing it with fewer carbs. So Dr. Bernstein has taught a lot of people through his book, The Diabetes Solution for Type 1 Diabetes. And while you can't get off insulin if you're type 1, you can have almost perfect blood sugar control, blood glucose control, because you're not putting in the same amount of carbohydrate that the insulin level. So he taught me that and it makes sense, you have to reduce the input of carbs to the system in order to get good control.
Sure.
But classically, the regular doctors didn't understand that you didn't have to eat carbohydrates. So most type 1s are taught to eat carbs and to just give insulin, but then you're never going to get good control. So a father of a child with diabetes, Mr. Deichmann, set up a Facebook group called Type 1 Grit. And this is kind of the advanced, I'll meet someone, I'll teach them, but you got to join this Facebook group called Type 1 Grit. It's TYPEONEGRIT, because there are thousands of people now in that, or parents of people with type 1, who are all doing a keto diet, and they'll teach you how to do it and fine tune it. One of my fellows at Duke in endocrinology wanted a project, and so she surveyed the members of Type 1 GRIT, what they were doing, how much insulin they were taking, and then Dr. Ludwig at Harvard redid it with validation of the self-report at doctors' offices. It led to a survey publication in the journal Pediatrics in 2018, and it was the most cited publication in pediatrics that year.
Wow.
So the Type 1 GRIT but don't expect your mainstream endocrinologist to know about it. They're focused on the medication,
Right.
And they might even be fine-tuning the insulin pump with different types of insulin throughout the day and a feedback loop system, and they're focused when all you have to do is cut the carbs and you get
Sure.
the blood sugars. And what I'm told is that people with Type 1 really do a keto diet so that they don't have hypoglycemic events anymore. They don't have the feared hypo, when you're driving or at night.
Right.
Yeah.
Right.
And so, yeah, that's fascinating how, again, it's kind of a grassroots change. It's a theme in keto and in low carb. It's the athletes doing it on their own. It's the Type 1. It's
Right.
another group of myocardial disease people with a disease that doesn't allow their muscle to store glycogen, and they basically fix themselves. And I met these people at a meeting. We published a paper. They had a group, an interest group put together, and it's the tail wagging the dog, so to speak, of people already doing it. And now the university academics are like, oh, maybe we should study it now.
Sure. It's often the case on something that's being pioneered. There is a lot of diagnoses here in the phase 1 that this can help. One I was kind of interested in was IBS, irritable bowel syndrome. So both my daughter and I had trouble with bloating and really upset stomachs. And Mike had this problem 2 years ago. And we went on the FODMAP diet. I'm sure you're familiar with it. And it seems very similar to, in some extent. I wonder if I would have probably been fine if I would have gone on the keto diet and maybe would have took care of the problem too. Do you have any experience with that or any thoughts?
Yeah, so the FODMAP, I always, F for fructose.
Fermentable.
Oligosaccharide. These are basically the simple sugars.
Right.
All put in an acronym, FODMAP. Well, on a keto diet, you get no simple sugars.
Mm-hmm.
But also you don't have gluten, you don't have all these other things. So a keto diet's like a FODMAP diet on steroids.
Sure.
So if you got benefit from FODMAP, you'll get a lot of benefit from a low carb keto diet.
Yeah.
It's even stronger. And yeah, the gurgly, the bloating, the pain, all that goes away. The heartburn goes away 100%.
I had GERD and really bad bloating, and I didn't try to resolute that with keto. I just tried keto because I was curious. And I am like, when I tried keto, I was in my late 20s. I'm in my early 30s now, but all that bloating and gas just went away. And then later on, I heard about FODMAP, and then I kind of saw the correlation. I'm like, well, I cut out all these, huge food groups, and then it just kind of fixed itself, honestly.
Yeah, if you had a Venn diagram of low carb keto and FODMAP, the overlap is basically the absence of the simple sugars.
Sure.
But on a traditional FODMAP diet, it's not a low carb diet.
Mm-hmm.
It's not a keto diet. So if you're sensitive to those other things, or you're trying to lose weight, it doesn't work all that well because it's not designed for that. So it's almost like I see these researchers inching in this area, and I'm like, just take the lead. But then you get the litany of 10 things, but then you feed more fat,
right?
And then what about the cholesterol, and what about
Yeah, I think it's one of those diets you just have to try. Like, you don't understand it. Like, you can research as much as you want about it, but until you experience it, you don't know.
I don't know how this works. I don't know how it works.
Sure.
But it's really useful.
Right.
The smartphone. So you don't need to really know how it works, right?
Mhm.
Mike had a question on adherence to the diet, whether, people have trouble with that. But, my experience with the FODMAP diet and my daughter's experience is, you feel so good. It's such a motivator to stay on it. And I don't know if that's what you're finding with your patients, or do some have just trouble with the repetitive nature of it?
Well, there's a whole range. You take any sort of dietary change or lifestyle change. Some people will do it, some people won't, and those who get the best clinical benefit tend to stay with it. So I don't say that you need to do keto forever, but a lot of people do, because they have great energy. They are able to live life in a way without worry about food. If you're hungry all day long and obsessive thinking about food, that goes away. So there are a lot of things beyond the medical problems that get better. But there's very few people who are happier than the people I can get off insulin shots.
Right.
And then not having to check, but the medical world's trying to make it simpler, right? Well, you don't have to check this, you just check the CCM on the arm, and we'll make the needle really small so you can, no, you don't have to do any of that stuff.
Right.
But there's a teaching of and adapting it to someone's own personal lifestyle. That's kind of the art of doing this, and lots of different people. And it's important to handle the issues with the family, if there are carb eaters in the house, and whether someone's shopping at a very expensive grocery store or not expensive, whether someone's going to fast food or restaurants. That's kind of the art of implementing it. But the main thing is to keep the carbs really low. There's a lot of behavioral stuff, I have to admit, that I just repeat. I give people praise for not having breakfast. And that's a funny thing, because people will come in, and I didn't have breakfast. Oh, good.
Sure.
Because everyone else told them you have to have breakfast. And breakfast is the most important meal of the day. Well, who came up with that? The cereal manufacturers.
Cereal companies. Exactly. They're also the ones that came up with the idea that you need to exercise to lose weight.
Well, that was the big distraction.
Right.
Played out in actually a very well-renowned research program. Got in a lot of trouble because it surfaced that they were getting $1 million from Coca-Cola to study exercise.
Sure.
And I'd always wondered why, he's a colleague of mine, why he never talked about food or diet. He only talked about exercise. And when they did a diet study, it was kind of a wimpy sort of thing, a survey sort of thing. And it's because if you fund a program to study something that's different, they have a lot to do. There's a lot of research to do there, but then it's like, it implies that you don't have to worry about it, or it's not important. The tobacco industry did the same thing.
Sure.
And the sugar industry is getting called out for that sort of manipulation of researchers intentionally. And that's kind of sad to see. Yeah, we got to be a little more, a little less naive about the intent of people who are getting money.
Yes, exactly. Well, how about a couple more questions, Mike? Why don't you ask one and I'll ask one yet?
Sure. I guess just a good question to ask. Have you ever found anyone, a patient or yourself, that the keto diet just really didn't work well for them, or they had some negative health effects come with it? Because you always hear the doctors say it's fine short term, but not long term. And I've heard you talk about this in other videos, so I just want you to repeat it for the audience, I guess.
Well, there was such concern about low carb keto diets that it's now basically one of the most studied diets of all time, because people were concerned about it. And the kind of ironic upshot of that is people didn't do the second study. So there are all of these people who did the first study and they didn't find it bad, so they didn't find what they wanted, so they stopped studying it.
Oh my gosh.
Which is, you would think you would follow that signal,
right?
But they weren't trying to find something that worked. They were trying to show that it was bad.
Yeah. Well, so that the Minnesota coronary something study that was done. Is that the one you're talking about?
Even then, some studies were buried because they didn't find the results that they wanted.
Yeah.
I think that was unearthed, 10 years or 15 years later. And then an investigator actually was interviewed and said, well, it didn't find what we wanted, so we didn't publish it.
Yeah.
Oh God.
No,
Yeah, that was the group with whatchamacallit in it. Can't think of that guy. What's that guy's name from the 1950s that treated the
well,
president?
Ansel Keys.
Yeah, there we go. Thank you. I couldn't think of it.
I have to say, Professor Keys is beloved at the University of Minnesota and probably brought a lot of money in, I'm sure, and with the epidemiology sort of group. And even Ansel Keys thought cholesterol was not an issue by the end of his career. So actually, a lot of people use his early work to say when they don't follow his later work, because they're not really following Ansel Keys, they're following the idea that you shouldn't have fat.
Sure.
Yeah.
And that you should worry about
What
cholesterol.
fits for them. Yeah.
But, back to your point, yeah, there are a lot of behavioral things that will make a keto diet not be comfortable, or I work with people to make it satisfying, but a lot of people are just overtly addicted to sugar.
Sure.
And you need to get them out of that. There are some people who really, they can't wrap their head around not exercising so much. And so what's fascinating, and it's just what I see, is that occasionally someone's exercising too much, so their hunger doesn't go away automatically.
Sure.
And so the automatic reduction in calories and energy doesn't work. Now, any kind of lifestyle is associated with medical things. I mean, that is something you have to be aware of. Any sort of free living people can get heart disease, right? I mean, I don't say that this is a panacea that is going to fix heart disease. We know it lowers cardiometabolic risk by lowering metabolic syndrome. But, if heart disease is from smoking and you don't quit smoking,
Right.
the diet's not going to fix that.
Right.
There's initially there's a phenomenon where I can give someone, for example, or introduce a new diet, and they might get a gout flare. But the gout flare is actually a temporary thing, and the fixing of the gout is fixing the weight in the long run and fixing the metabolism. So there are a lot of things that you'll talk to doctors, well, that causes gout. Well, actually, after you get over that flare and people stay on it, they lose weight, then they don't get it again. And then there's a need now for randomized trials to look at the rates of different things, how common things are. And randomized trials can give you a comparison group to say, well, okay, you have a certain event rate in this group, but how common is it in the other group? For example, there are some people who get kidney stones, and they may have pre-existing stones and they are just passing it because of the diuretic effect of the diet, or they might be making new ones, but that happens regardless of what diet you're doing. Sure. And the rate seems to be something like 1 in 500 or something. So we don't have it as a warning up front or anything. If someone has a history of gout or kidney stones, I will use special language to say, you really need to drink lots of fluids like your kidney stone doctor told you, because a lot of people say, I don't really follow those directions anymore. And then, in general, the restrictions that were on the diet before have to be carried over onto the keto diet. For example, the salt restriction if you have heart failure or a salt sensitive blood pressure. That's where, if you have these medical issues, you want to work with a doctor who understands how to change these things. But I think it's a healthy way of eating. Sure. So I'm not concerned. Of course, I've heard of the same concerns for 20 years now, and the concerns haven't materialized. So in an editorial last fall, I wrote in the paper, there's so much evidence now for it, a low carb keto diet. If someone has a concern, they have to show data about it being concerning. Sure. Because the burden of proof now is on y'all
the other
who
side.
say it's bad, because there's so much evidence that shows how good it is. Of course, I doubt anyone's read that editorial.
Well, a
Yeah.
couple, I think the Diabetic Association even posted on their website now that keto is a option of a diet to use. And I think
Yes.
the College of Cardiologists also posted they want like the guidelines to be reworded, saying like high fat with high carbs isn't a good option, but high fat in itself is fine.
Oh, fantastic.
I think that was last summer I saw that they're posting that, but
Well, if you wait for guidelines to change, it can take a long time. And the last one that's going to change is the U.S., the group that created the food pyramid. I mean,
yeah.
it's
Yeah.
so entrenched
Yes.
with the policy and the congressional interests for
Right.
agricultural production.
Basically.
Yeah.
Well, again, I want to be respectful of your time. You've given us so much time today. This has been fantastic. But I was just going to ask you one last thing. Do you just want to mention sugar substitutes, whether you can use them, and also you can talk about sugar alcohols?
Yeah, in my clinical practice, I let people use any sort of sweet thing that's not sugar. So it could be sucralose, NutraSweet, sugar alcohols, stevia. These are all fine. And the best one, I think, is the one that they can tolerate the best. Because, the last thing I want to do is say, here, try this. And then they come back a month later. Well, I didn't like that one. And then, well, what about this one? So I let people choose from an array of foods. I don't take a whole lot of time telling people what to eat. I say, choose what you like from this list. And then if you want to choose from any of these other sweeteners, that's fine. When you use total carbs, not net carbs, you include sugar alcohols and some of these sweeteners in that carb calculation. So you're allowed fewer sugar alcohols and sweeteners than if you were using net carbs. And I think that's what makes this stronger. The total carb method is like the prescription strength, 20-gram prescription strength, that in over-the-counter medicines work. That's using net carbs. It's just they're not quite as powerful. So I kind of categorize that as a higher carb or using net carbs is just not quite as effective. But I've had people use all those artificial sweeteners or stevia, which is not, stevia is a real, not artificial food, but I don't give it extra credibility because it's natural. They're natural poisons, right? So it's more what is the metabolic effect of those things. In the long run, if someone's doing this 6 months or a year and in the clinic, then I'm going to bring up the idea, do you really need those things? Do you really need sweet things? And for most people, they're sort of automatically reducing the amount of sweet things. And some people just stop automatically on their own. Let me put it a different way. I don't know of any long-term health benefit of having stevia, right? Sure. It's never been studied like a drug that you're going to live longer. But it's useful to use these to get people off sugar at first.
Well, thanks again, Dr. Westman. It's Eric C. Westman, and his book is End Your Carb Confusion, a simple guide to customize your carb intake for optimal health. Just awesome book. He's got several other books that he's co-authored. You have a website. You have where is it at? adaptyourlifeacademy.com. Is that the main one that people can get a hold of?
Yes, adaptyourlifeacademy.com is the educational website where we have classes that you can sign up for and learn more. And then we actually help people get started in a personalized group so that we can overcome that initial hurdle for a lot of people. They're not sure. And all that. We'll say, look, we'll give you 3 weeks in a dedicated group so that we can get you over the hump to get started.
Oh, that's terrific. That's a fantastic way to approach this. So, Dr. Westman, anything else that we failed to mention? Or I know we covered a lot of ground here. Love to have you on the show another time. You're just a fountain of knowledge. So
anything. Thank you for your interest. And it really is so helpful for so many different people I'm
It is.
so glad you're getting the word out.
Thank you.